And at the end of a period of time of an episode, be it a heart failure in the hospital or a cold in the office, we will tally up all the costs associated with the episode as defined, and then after a year, a principal accountable provider, or a PAP, has those costs attributed to them, and their average cost on every one of their episodes, a lot of times risk adjusted, included, and also getting rid of exclusions, would then be used to determine their relative performance to their peers. So we will have what we call PAPs, or principal accountable providers, who will be accountable for all the costs. In these two episodes, for hip and knee, it'll be the orthopedic surgeon. For congestive heart failure, it'll be the hospital because of a team of people taking care of the patient, from the ER doctor to the hospitalist to the specialist, and then planning for discharge, the discharge planning specialist. So in each case, the quarterback of the episode, who will coordinate and be responsible for the coordination of care and drive improvement, would either be the surgeon for hip and knee or the hospital for heart failure. And again, the plan here is to deal with issues related to practice variation. So we want to reward those providers who meet certain quality metrics, but at the same time get good outcomes while managing health system resources. Next slide. So as I've said, while this is kind of driven to look at your effectiveness managing health system resources to get a good quality outcome, we do have some quality metrics. So we're going to limit the gain sharing or the financial incentives to only those PAPs, or principal accountable providers, that can pass certain quality metrics. Some quality metrics are required, and some are just for reporting, so we can monitor the performance of the healthcare system. But again, unlike the pay-for-performance program we have for hospitals, where you have to get an A or an A- to get bonuses, here we want you to get a B or a B-, show that you've given a basic solid performance on your episodes of care to qualify to receive any financial incentives from gain sharing. Next slide. And again, the overall framework here of this, what we call retrospective reconciliation, is that everyone is just getting care just like they are now. Your business operations are just like they are now. People see care, people get paid, and they get reimbursed. So as if nothing has changed. A new slide. What has changed is that we have designated a PAP. That person, over the long haul of a year's worth of episodes, is responsible for the average cost of these episodes, and that's total cost of care, not just the care that they themselves bill for. At the end of that year, their average cost per episode is arrayed against their peers who perform similar episodes, and depending on how they fall in that normative or comparative arrangement, they could be qualifying for risk sharing or gain sharing. Next slide. So here is an example of a somewhat steep curve where you have each of the little bars, vertical bars, represents a principal accountable provider's average cost per episode. And those at the end of the year who are in pink and are above the acceptable line, they would be at risk for 50% of the average cost per case above the pink line. So if their average cost was $200 above the acceptable line, they would essentially owe Medicaid or the other payers, depending on the arrangement with that episode, $100 or 50% per case that's above, on average, that they did for that year. Now, we also give folks plenty of notice, so we're hoping that nobody is in that pink or red zone. If you see the line that says accountable to commendable, those folks are in gray, and for those folks, they have that's where their average cost per episode resides. They did that over the year, and basically they move on to the next year. They're not at risk for risk sharing. They're not in a position for gain sharing. They got paid their fee for service, and that's about the end of the story. And then finally, you have the folks in green, the lighter green, between commendable and gain sharing. Those folks actually got below the commendable line, so they're going to share in their savings, assuming they pass the quality metrics. So for those folks, if they were $200 on average below the commendable line, they would receive $100 per case for the number of cases they did for that payer. Now, in order to play safe and not have people take unnecessary shortcuts, we have put what we call a gain sharing limit or floor. We did this by calculating what we thought would be an appropriate or kind of rock bottom way of providing these services. And so at that point, they would not gain further if they ended up below the gain sharing limit. Those providers would, though, get the maximum gain sharing possible, as they would basically get all the line between commendable and gain sharing, just nothing beyond that. So they would be the biggest gainers, or tied for the biggest gainers in the system for their effective care that met quality metrics. So next slide. Let me go back to the old slide. Go back one. So let me tell you a little bit about the heart failure and total joint replacement episode. The total joint episode combines hips and knees. We have basically made a cost adjustment for the knees because they tend to be about 9% more expensive than hips. So they've been normalized to basically have equivalent outcomes in terms of cost. The episode begins 30 days prior to surgery when they see the PAP, which is the surgeon, and ends 90 days post-surgery. There is an all-cause readmission clause, so any patient gets readmitted for any cause, minus the exclusions that have been identified by CMS in their Medicare readmissions program. Those readmissions would count. Between 30 and 90 days, only readmissions that relate to the total joint procedure would count for the episode of care. There are really no major risk adjustments for some comorbidities, as this is an elective procedure, so that patients who have comorbidities not related to the joint itself, that would be part of your patient selection determination. However, there are some patients getting total joints for specific health needs, like patients who have sickle cell or rheumatoid arthritis. Those patients may be risk adjusted because their total joint replacement may be more costly, but it reflects their baseline disease that brought about the total joint injury in the first place. However, we do expect the principal accountable providers to be selecting those patients that would do well with a total joint replacement, as this is a very elective procedure. Now, when we did the thresholding, go back one more, go forward one. Thank you. So in this particular case, when we looked at the diversion of care, the range of cares, there was a difference of about $7,000 between the acceptable line and the gain sharing line, or about $4,500 between commendable acceptable, and about $3,000 on the thresholding between commendable and gain sharing. At this point, we require that you have to have done at least 5 cases to be in the episodes of care framework for gain sharing or risk sharing. And at this point, last year, no one was in the risk sharing mode for total joint replacement. In terms of the heart failure episode, that one begins 30 days. It begins on admission to the hospital and ends 30 days after the admission. And again, all readmissions would be counted, minus the exclusions for readmissions used by CMS in their Medicare program. The PAP is the hospital. We have quality metrics that essentially mirror that for the Medicare program, prescribing ACE inhibitors, discharge instructions for CHF going home, documentation of left ventricular systolic function. We also note that in terms of the Medicaid reimbursement, that again you have to have at least 5 cases a year. There is about a $3,000 difference between the commendable and the gain sharing limit, or about $2,000 between acceptable and commendable, and about $1,500 between commendable and gain sharing. So that's the main framework for that episode of care. Again, it's triggered on admission, and it goes for 30 days post-discharge. That would include all readmissions with the exception of those excluded by the Medicare readmissions metric.